Your doctor just scheduled another routine screening. And like most people, you probably didn't question it. Why would you? It's preventive care. It's supposed to help you stay healthy. It's what responsible people do. But what if I told you that after the age of 65, some of these routine tests can quietly do more harm than good? Not because your doctor is careless, and not because medicine is broken, but because the system is designed to find problems, even when those problems were never going to hurt you. My name is Dr. Kendra Harris. I've spent more than 2 decades working with patients over 60, helping them navigate one of the most misunderstood parts of modern healthcare, knowing when to act and when to leave things alone. And today, I'm going to walk you through 4 medical checkups that I personally approach with extreme caution after 65. Not because I don't believe in prevention, I do, but because I've seen again and again what happens after these tests find something, and what happens next is rarely what patients expect. Before we get into the list, there's one concept you need to understand, because once you see it, you'll never look at medical testing the same way again. It's called the cascade effect. Here's how it works. You go in for a routine test. Maybe you feel completely fine. The test finds something small, unclear, probably nothing, but probably isn't good enough in medicine. So your doctor orders another test. That second test shows something slightly different. Now you're referred to a specialist. The specialist recommends a minor procedure, just to be safe. That procedure leads to a complication. The complication requires treatment. And suddenly, 6 months later, you're taking new medications, managing new diagnoses, feeling worse than when this all started. I've watched this exact sequence unfold more times than I can count, not because anyone made a mistake, but because once something is found, medicine is designed to respond. The problem is, not every finding needs a response, especially in an older body, because as we age, our bodies naturally develop changes, small things, harmless things, tiny cysts, minor calcifications, slow, stable abnormalities that have been there for years, sometimes decades, without causing any issues. But modern testing doesn't know the difference between something dangerous and something simply there. And once it shows up on a report, it's almost impossible to ignore. Let me show you exactly what I mean. I had a patient, I'll call her Margaret. She was 72, sharp, independent, active. She walked into her annual checkup feeling completely fine. No symptoms, no complaints, just doing what she thought she was supposed to do. One routine test came back, slightly abnormal. Nothing urgent, nothing alarming, but enough to start asking questions. And what followed over the next several months was a chain reaction that changed her life in ways she never saw coming. We'll come back to Margaret, because the question she asked me afterward is the one question every person over 65 should ask before agreeing to any medical test. But first, let's talk about the first checkup. And this one might surprise you. Let's start with the first one. Checkup number 1, routine full-body CT scans. On the surface, this sounds like the smartest thing you could possibly do. A single scan, from head to pelvis. A complete picture of what's happening inside your body. No guessing, no blind spots, no missed problems. It's often marketed as the ultimate advantage, especially for people who want to stay ahead of disease. But here's the reality most people aren't told. After the age of 65, a full-body CT scan will almost always find something, not because something is wrong, but because aging bodies naturally accumulate changes over time. Small lung nodules that have been stable for years, tiny cysts on the liver or kidneys, minor spinal changes that are simply part of getting older. There's even a medical term for this: incidental findings, things discovered by accident, that were never causing symptoms, and were never going to. But once they appear on a scan report, they don't feel incidental anymore. They feel like a problem. And this is where the cascade begins. A small nodule in the lung? Now you need follow-up scans every 6 months. Those scans expose you to more radiation. And over time, that exposure adds up. At 65 and beyond, your body doesn't repair radiation damage as efficiently as it once did. So what started as a preventive scan quietly becomes repeated exposure to something that carries its own risk. And sometimes those follow-up scans don't look exactly the same. Not worse, just slightly different. But in medicine, slightly different often leads to the next step, a biopsy. And biopsies, especially in older adults, are not risk-free. Bleeding, infection, even lung collapse in certain cases, all from investigating something that may have never mattered in the first place. Studies have shown that a significant percentage of full-body scans lead to additional testing, and most of those findings turn out to be clinically insignificant. But the process of chasing them down, that's where real harm can happen. So before agreeing to a full-body CT scan, there's one question you need to ask. Do I have symptoms that this scan is meant to investigate? If the answer is no, you're not looking for a known problem. You're opening the door to finding something random, and potentially starting a cascade you never needed. Now, this next checkup is different because it does have value at the right time. But after a certain age, the benefits quietly begin to shift. And most people are never told when that shift happens. Checkup number 2, routine bone density scans after age 80. Now this one is important, because earlier in life, this test can be incredibly useful. A bone density scan, often called a DEXA scan, measures how strong your bones are. In your 50s and 60s, this matters. Because if low bone density is detected early, there's time to intervene. Lifestyle changes, targeted treatment, steps that can actually reduce fracture risk over the next decade. At that stage, the benefit is clear. But after 80, the equation starts to change, quietly but significantly. Here's what usually happens. An 82-year-old patient goes in for a routine scan. The result comes back showing osteoporosis. And from a clinical standpoint, the next step is almost automatic. Medication. Typically drugs called bisphosphonates. These medications are designed to increase bone density and reduce fracture risk. And on paper, they do exactly that. But here's where it gets complicated. Because in very elderly patients, the risks associated with these medications begin to rise. One of the most concerning is something called an atypical femur fracture. It sounds technical, but the idea is simple. With long-term use, certain bones can become brittle in unusual ways, leading to fractures that occur with very little force and are extremely difficult to recover from at an advanced age. There's also another condition, osteonecrosis of the jaw. A rare but serious issue where the jawbone begins to deteriorate, especially after dental procedures. Now, these risks are not common, but they are real. And when you weigh them against the actual benefit at age 80 or beyond, the conversation starts to look very different. Because here's the deeper issue. At that stage in life, most fractures don't happen because of bone density alone. They happen because of falls, loss of balance, muscle weakness, medications that cause dizziness, environmental hazards inside the home. In other words, the biggest risk isn't just fragile bones, it's falling. And this is where many care plans miss the point. Because treating a scan result is not the same as preventing the actual problem. There is strong evidence showing that fall prevention strategies, balance training, strength exercises, home safety adjustments, medication reviews, these interventions can reduce fracture risk more effectively than focusing on bone density numbers alone in very elderly patients. So if a bone density scan is suggested after 80, here's the question that matters. Will this result change what we actually do beyond what we should already be doing to prevent falls? If the answer is no, then the scan may be measuring something without meaningfully improving your outcome. Now, the next checkup might sound completely logical on the surface. It's about preventing stroke. And that's exactly why so many people agree to it without hesitation. But when you look closely at the evidence, the story becomes much more complicated. Checkup number 3, carotid artery ultrasound, without symptoms. This is one of those tests that sounds completely logical. The carotid arteries run along both sides of your neck. They supply blood directly to your brain. Over time, plaque can build up inside these arteries, narrowing them. And if a piece of that plaque breaks loose, it can travel to the brain and cause a stroke. So naturally, the idea makes sense. Scan the arteries. Find the blockage early. Fix it before anything happens. Simple, reassuring, preventive. But here's where the reality starts to shift. Because detecting narrowing in someone without symptoms doesn't always lead to a better outcome. In fact, in many cases, it leads to a difficult decision If the scan shows significant narrowing, the next step is often a procedure called carotid endarterectomy, a surgery where the artery is opened and the plaque is physically removed. Now, this procedure can absolutely be life-saving in patients who already have symptoms, like a mini stroke or TIA. In those cases, the benefit is clear. But in patients over 65 who have no symptoms at all, the equation becomes much less certain because the surgery itself carries a risk, and not a small one. During or shortly after the procedure, there is a real chance of causing the very thing it's meant to prevent, a stroke. Think about that for a second. You go in feeling completely fine. No warning signs, no issues. A scan finds narrowing. You have surgery to prevent a stroke, and the procedure itself creates that risk. Multiple large studies have looked at this exact situation, and what they found is important. For many asymptomatic patients, especially older adults, the risk of stroke from surgery can be equal to, or sometimes even higher than, the risk of doing nothing and managing the condition with medication. In other words, the test finds something. The something leads to intervention, and the intervention may not improve your outcome. This is the cascade in one of its clearest forms. And yet, despite this, carotid ultrasound screening is still commonly ordered for people who have no symptoms at all. So before agreeing to this test, ask a very direct question. If this scan finds narrowing, what are the real risks of surgery compared to simply managing this with medication? Not a general answer. Ask for your risk, your age, your health profile, because in many cases, careful medical management, blood pressure control, cholesterol treatment, lifestyle adjustments can reduce stroke risk effectively without exposing you to surgical complications. Now, the final checkup on this list is the one I approach with the most caution because it doesn't just carry risk. It can set off a chain of events that feels urgent, aggressive, and difficult to stop once it begins. And for patients without symptoms, it may offer far less benefit than people assume. Checkup number 4, aggressive cardiac catheterization. After a positive stress test in someone with no symptoms. This is the one I'm most careful about, because once this process starts, it can escalate very quickly. Here's how it usually happens. Someone over 65 goes in for a routine cardiac stress test. No chest pain, no shortness of breath, no warning signs at all, just a precaution. The test comes back abnormal, not definitive, but concerning enough to take seriously. And from there, the next step is often recommended, cardiac catheterization, a procedure where a thin tube is inserted through an artery, usually in the wrist or groin, and guided up to the heart. Dye is injected, images are taken, and any narrowing in the coronary arteries is identified. If a blockage is found, that can lead to stents, or even bypass surgery. Now, in patients with clear symptoms, this can be life-saving, but in patients with no symptoms, this is where the evidence becomes very important. Large clinical trials have looked at this exact situation, and what they found surprised many people. For patients with stable heart disease and no significant symptoms, aggressive procedures like catheterization and stenting did not reduce the risk of heart attack or death compared to medical therapy alone. In other words, carefully managed medications achieve the same outcomes without exposing patients to the risks of invasive procedures. And those risks are real. Bleeding, damage to blood vessels, kidney injury from the contrast dye, and in rare cases, stroke, especially in older adults, where the body is less resilient to these stresses. There's another layer to this. Stress tests themselves can produce false positives, particularly as we age. So a result that looks abnormal may not actually represent a dangerous blockage. But once that result appears, it creates urgency, concern, pressure to do something, and that's how the cascade accelerates. So before agreeing to cardiac catheterization, pause and ask, do I have symptoms that justify this procedure? And what does the evidence say about outcomes for someone like me with medication alone? Because in many cases, the safest path is not the most aggressive one. Now, let's come back to Margaret. After everything she went through, after months of tests, treatments, and complications, she asked me a question I will never forget. She said, Doctor, if I could go back, what's the one thing I should have asked before that first test? And my answer was simple. It's always the same question. If this test finds something, what will we do about it? And more importantly, is that something worth doing for me? That one question changes everything because it forces the conversation most people never have. It shifts the focus from finding problems to understanding consequences. Let me be clear. This is not about avoiding your doctor. Preventive care saves lives, blood pressure control, diabetes management, vaccinations, vision and hearing checks. These matter. What this is about is making sure every test you agree to actually serves you, not just the system. So the next time a screening is suggested, pause, ask the question. Because sometimes the most dangerous step in healthcare is the one that feels routine. If this opened your eyes even a little, share it with someone over 65 who never questions their checkups. And if you want more clear, honest conversations about your health, subscribe, because understanding this takes more than one video. I'm Dr. Kendra Harris, and you deserve the full picture. Always.